Hi, my name's Andre and I've been called to a 55-year-old male who's collapsed following chest pain. When I've arrived on scene, the patient was lying on the floor, was pale, clammy and peripherally shut down. His eyes open only to pain and his verbal response is also only to pain. So he's got a reduced level of consciousness and he's currently not obeying commands. I've spoken to the family and they told me that when he collapsed, he told them that he had chest pain that was different to that when he'd had a MI 5 years ago. They've also told me he's got a history of hypertension and ischemic heart disease. He's currently on cilazapril and aspirin, so both cardiac medications. I've done a full assessment of Jim, including a 12 lead. So that's showing a heart rate of 170 with a wide complex tachycardia. His blood pressure is 70/40, so he's hypertensive. A rest rate of 24 and shallow. BGL of 7.6, so within a normal range, and a temperature of 37 degrees, so again a normal temperature. Looking at his 12 lead, I'm thinking that he's probably in VT. I need to make sure that I've excluded other possible differentials. So those could include SVT with abnormal conduction. So rather than a normal narrow complex SVT, it would appear wide. It's quite unlikely that Jim's in SVT because SVT generally occurs in younger patients. It also rarely causes severe cardiac compromise, and often people who have had SVT in the past have been treated successfully with adenosine. Now, if Jim was an SVT, it would make no difference to our treatment. If he was an SVT and severely compromised, we'd still cardiovert him. He may have sepsis and an infection. However, his temperature is normal, and in my examination I haven't been able to find any other symptoms that would lead me to think he's had some form of infection. This sort of heart rhythm could also be caused by electrolyte imbalances. So looking at the 12 lead, I haven't seen any signs of peaked T waves, so that would tend to exclude hyperkalemia. Jim is in cardiogenic shock, and so I've obtained 2 IVs, and I've currently got a bag of saline running to increase his blood pressure and to treat the cardiogenic shock. I've also got him on 6 litres a minute of oxygen via an acute mask, again to treat the cardiogenic shock and to ventilate him and avoid hypoxia. I've placed pads in the apex and sternal position, and I've placed Jim in a supine position. In this case he's on the stretcher, but it could be just as easily be on the floor at home if we were dealing with him there. I've got my resuscitation equipment ready, so there's a bag valve mask, LMAs are out if I need them, and I need to resuscitate Jim. In terms of the IV access, if I hadn't been able to achieve that, then I would have looked at speaking to the clinical desk about IR access. So what I'm going to do now is work through the cardioversion checklist and then look at cardioverting Jim. Working through with my partner.
Place pads in either the apex, sternum or anterior posterior position in addition to ECG electrodes.
So they're in that position. 12 lead electrodes are still on, so I can take a 12 lead and see if there's been any changes after cardioversion.
Ensure the defibrillator is in manual mode.
Yes, it's in manual mode, and I can check that by just pushing the charge button and 360 joules. Yep.
Select a lead with a visible R wave and ensure that artifact is minimised.
Okay, so I've got 3 leads here with visible R waves and there's no artifact.
Select synchronised mode.
Okay, so pushing synchronised.
Confirm there is a detection symbol above every QRS complex.
Okay, I'm seeing detection symbols on the complexes, and I'm going to just print out a short strip just to confirm that. Yep, and we've got detection symbols on there.
Ensure the patient has received adequate sedation if indicated.
Okay, so Jim is severely compromised, so we haven't given him any sedation. He could have ketamine in consultation with the clinical desk if need be, but I'm just going to check that he's still severely compromised. Jim, there's still no response from him and he's not obeying commands.
Select the joules, charge the defibrillator, and confirm everyone is clear.
Okay, so I'm going to select maximum joules, 360, charging. And all clear. Yep, everyone is clear.
Press and hold the shock button until the shock is delivered.
Shocking now. And delivered.
Determine the rhythm and the level of cardiovascular compromise.
So looking at the rhythm, there's been no change. Jim's still in VT. And Jim, no, there's been no change in Jim's level of compromise. So he's still severely compromised. So we can cardiovert twice. So I'll get you just to quickly run through the checklist and we'll cardiovert the second time.
If administering a second cardioversion, confirm the defibrillator is still in synchronised mode.
Yes, we're still in synchronised mode.
Confirm there is a detection symbol above every QRS complex.
Yes, I've got a detection signal, and again I'll quickly just print off a strip to confirm that. Yep, we have that.
Ensure the patient has received adequate sedation if indicated.
Jim, so there's been no change to Jim's level of compromise or level of consciousness.
Select the joules, charge the defibrillator, and confirm everyone is clear.
So 360 joules, charging. And all clear.
Press and hold the shock button until the shock is delivered.
Shocking now. Yep, shock's delivered.
Determine the rhythm and the level of cardiovascular compromise.
So we're still in VT. Jim's still severely compromised. So our plan now is that we are going to call for ICP backup for chemical cardioversion, and we're going to be transporting towards that backup.